All right, so good day to everyone. Welcome back. This is our fourth session in the WIN webinar for 2025. Very happy to have everyone on board today. We have some very interesting two speakers today. And we also, for the first time, we will be doing something special as in introducing WINs from different countries, especially countries which have just started to invite more women into their society. So we like to focus more on the younger from these countries, so that in future we will have more women to take over this kind of webinars. All right, so for today, Prof. Kato, you want to say anything or should I just go ahead?
Thanks so much. So today is the Easter, so everybody is rushed to finish the WIN webinar.
Yeah, today is actually Easter. Yeah, Easter
yes.
Sunday.
You too, of course.
Yeah, so happy Easter to everyone.
Yes.
And we start off today. Our chair is Prof. Satoru Miyake. Good day to you, Prof. Prof is an associate professor from Department of Neurosurgery, Faculty of Medicine, University of Tokyo, Japan. So I'll give him over the webinar for today, as he's the chair, to introduce our two esteemed speakers, and then to continue at the end of it, because he will give us some learning points. Okay, Prof. Miyake, are you around?
Miyake Sensei will join us soon, I think, in a few minutes.
Will join us. So yeah, because he's or shall I just start off with Prof. Alessandro, because he has to leave early today. So Prof. Alessandro Boro, are you ready? So today, Prof.
Yes, absolutely.
Yes. So he's from the Department of Neurosciences, Biomedicine and Movement Sciences from University of Verona. And today he will be talking on a very interesting subject that I think all of us are always interested in, is AI in neurosurgery. Are we ready? So you can have.
Okay, so I'm going to share my screen. Okay. Can you see my screen?
Yes, you can see clearly.
Yes. Okay, perfect. So first of all, thank you very much for the kind invitation. It's an honor for me to take part of these webinars, it's always a pleasure to share knowledge, opinions, and time with the ACNS. So thank you very much for that. So the topic I'm going to talk about today is, as you said, AI in neurosurgery. Are we ready? So why is this relevant? If you go into PubMed and if you take a look at the results that you get when you type artificial intelligence in the search engine, this is what you get. You get that between 1996 and 2005, we got around 16,000 results in terms of paper. If you shift forward 10 years, you get almost 50,000 results. And if you go over the last 10 years, these results go up to more than 200,000. It means that there is an almost geometrical increase in the number of papers. So there is a really strong interest in terms of scientific interest in the AI. And this is really the same also when you go into a different environment, which is the market. A lot of, as you know, companies are focusing on developing artificial intelligence solution for medicine, surgery, and this is really an explanatory slide, because this is the AI industry landscape in just the UK and just in 2021. So you can see the amount of companies, investor hubs dedicated to develop AI solutions. And so on one hand, we see there is really an explosive phenomenon. And so when we think about artificial intelligence as individuals, really think about direct solution to problems. So we can think about autonomous driving for cars, surgical robots, face recognition and segmentation algorithm, the large language model that we know about, GPT, 𝒓𝒐, or the virtual assistants. So we really think about something that can provide us a solution and ease our life on a daily basis. But if you start looking at the concept of AI, we see that there is quite depth to it. So I'm sure you are familiar with this slide where there is overall concept of artificial intelligence, and within this concept, subgroup developed in terms of the types of artificial intelligence techniques that you can think of. So this is one of the easiest one, the simplest one, with machine learning and deep learning concept. But we can also go further, and we see that within these different subgroups, there are different specific models that have different and specific characteristics to them. And if we take a look at different models within each, you can see there is really a lot of math, a complex math that needs to be developed in a rigorous way to provide a robust structure. And so we find ourselves in a condition in which, on one hand, we have a strong diffusion and the push towards the implementation of AI solution. We saw before the scientific push and the commercial push towards the use of these solutions, and which means that as neurosurgeon, in one way or another, we will be affected by these technologies. And on the other hand, we just saw that AI concepts and techniques can be complex, are complex. And so there is a need of a certain level of understanding that would allow us to fill this gap in order to be protagonists, in order to not suffer in a passive way the advent of this technology, but in order to be informed decision maker and users. And so this condition, this tension between the two contexts provides two important questions. One is, what do we know now as neurosurgeons about AI concepts? So where do we stand? What is the benchmark? And the other is, what should we know about AI concept in order to be informed users and policymakers? And so if you take a look at the last years, there are different works that have been done, quite interesting, regarding survey works mostly, to try to understand what is the attitude of neurosurgeons, but also patients, with regards to AI solution to be applied to the practice of neurosurgery. And what we find is that there is a positive attitude towards the implementation, and that the impact that AI can have on patient outcomes and on surgical practice is mostly beneficial. On the other hand, we see that the amount of AI application that are routinely used, both in the clinical environment and in the research environment, it's still low, which makes sense because even if we are talking about this technology for more than 10 years now, it's still in the early stage in terms of applicability of the solutions. And so with this in mind, we developed a survey that we use around the globe in order to try to understand what is the confidence and the level of knowledge of neurosurgeon with the AI concept. We know, as we found similar results as you saw before, that the attitude is positive. There is a sense of strong benefit that could come from this technology, but where do we start? And so this is just an overall picture of the survey. This blue square just represents some demographics that we put together, that we recorded from the participants, and the perspective and attitudes of the participants towards these technologies. And the really important part is this red square, because in this red square, we, with these 6 simple questions, we went to try to explore the level of confidence of neurosurgeons with the AI concept. And how did we do that? We basically asked if each of the participants knew, so it's a yes or no question, if they knew the meaning of 3 basic AI terms, which are machine learning, deep learning, and data. And so just to see what's their subjective knowledge about it. And then we actually took a step forward and we tested their knowledge. We provided definition and features of these terms, and we asked the participants to provide their opinion on it. Is this what is the correct definition of machine learning? Again, for deep learning, what are the main features of big data? And We obtained a total of 250 respondents from 61 countries, and most of the people, the participants, came from the academic environment and completed the residency. This is a key element to keep in mind, and we will see later why. And so these are the results that we had from our study. So when we asked the participants, do you know the machine learning? You can see here on the left that 70% of the participants said yes, they know what the meaning is. When they choose the definition of the machine learning term, only 62% were actually able to provide the correct one. And if we take a look at those people who said yes and actually were correct, we had a total of 60%, which means that over the overall population, less than 50%, 46%, were able to pinpoint the correct definition and knowingly so. When we go to the deep learning term, the numbers goes down even further. So we see that less than half, 46%, actually had confidence to say that they knew what deep learning term means. And when they went to, if we consider population, just 23% were able to provide the correct definition, knowing that that was the correct definition. And then if you go to the big data part of the survey, we have similar results. In addition, in this case, we asked if the participant could an example of a big data in neurosurgery. And it was interesting to see that more than a quarter, more than 25%, provided examples which were not appropriate. So, for example, answers were like robots or, for example, RCT. At this point, we tried to see if being in training, being of a younger age, and being part of an academic environment would skew the results one way or the other. So if you are younger and if you work in an academic environment, is it more likely that you provide the correct answer? As you see from this plot, it didn't really seem to be the case. So being in these factors weren't really correlated to the answer that we got. And so if we go back to our slide where we see there is this tension between the diffusion of AI solution and the complexity of the concept, we see the results of our survey can tell us that there is a moderate to high confidence, subjective confidence, but it's not correlated to a high level of knowledge. The knowledge tends to be low. So obviously we have to take into consideration that this survey is an e-survey with all the limitations and the bias correlated to it. But it's already a good result in terms of an insight of what the situation is around the neurosurgical community. And what showed us is that there is a gap between the knowledge that we have and the knowledge that we should have in order to provide, again, to be informed decision maker and be informed users of this technology, which are so difficult to implement. And this brings us to our other question, which is, why does it matter? What should we know? Why is it important to improve our knowledge about these concepts? This is important because of the implications of related to the AI solution, the way they works, the way they are implemented, and the outcomes that they provide. So, for example, if think about models that might be part of the more larger family of machine learning algorithm, of the deep learning algorithm, we know that there are some important differences in terms, for example, first of all, of explainability. So if we have a model that provides that takes to some data and provides an outcome, and we are able to see how the model were able to go from point A to point B, then we can trust in a way the reasoning of the model, because we will always be able to go back and understand how it did it. If we have a more complex and deep algorithm, in that case, it can become more difficult, sometimes almost impossible, to know how the algorithm were able to provide the outcome. And so this has to be taken into account, because if we, for example, have developed an algorithm to segment tumor in an MRI, it doesn't really matter how the algorithm went reason to provide the volume in the MRI, because we can always go back to the MRI, correct it if it's wrong, or in any way check it. But think, for example, of an algorithm which might be helping during a surgical operation to analyze data from the neuromonitoring machine, the anesthesia workstation, and would provide a surgical, a step-to-step, real-time surgical strategy. In this, we really want to know how the algorithm was built and what's the reason of the algorithm, because at the end of the day, we go to the next concept. We have to take into consideration the liability and the responsibility of what the outcomes of this AI solution mean, because for now, with the type of algorithms that are all now being used, the responsibility is still very clearly in the hand of the physician. But we have to see how the things, how the future will be. Something which is very important and very well known about the AI community is that really the algorithm that is developed relates with the type of data that is provided. So when we develop an algorithm, we have to make sure, and that's the most important step, in my opinion, in developing these models, to make sure that we provide adequate and high quality data to it in order to provide adequate and high quality outcomes. But it's not only a question of quality, because it's also a question of bias. Because, for example, if we develop an algorithm here in Italy with the health information of the Italian population, it's not really it doesn't necessarily be able to be this model. It doesn't necessarily work in another country, in Japan or in India or in the United States, because the people are different, and so we have to make sure that we know what we are applying and what were used to develop the algorithm as well. And then, and we'll go back to this concept later, it matters to improve the knowledge about AI, because we are now entering an era in which the figure of data scientist is becoming really preeminent, and it's fundamental importance, because it's not going to be the physicians, the surgeons to develop the model, it's going to be the data scientists. And in order to be able to understand this algorithm and make sure that they provide what we want for our work and for our patients, it's important, it's fundamental to develop a common language that allow us to collaborate from the very beginning. And so with this in mind, what can we do and what should we do? The most important thing is to provide the tools. As neurosurgeons, as neuroscientists, and as scientific, we have to do that. So on one hand, it's already begun thanks to the writing of resources, apart from the articles, books. We were asked back in 2021 to write the first AI and big data chapter in neurosurgery in the humans and WIN, but things move so fast that if you look at the chapter now, the large language models are not there, because back in 2020, 2019, when we started writing it, it wasn't even a thing. And so that's important to provide new tools. So, for example, the recently published computational neurosurgery from Professor 𝑑𝒓𝒐𝒏, which is even more extended in the topics that it provides. And from a more active point of view, it's starting already to do some important things. So, for example, the ACNS developed the AI subcommittee led by Professor Danilov, or the EANS, which started the E18 task force led by Professor Gábrovszky. And these are very important because this would allow to develop webinars, like, for example, the one that we're doing today, but also make sure that the community stay up to date thanks to presentation and workshop during congresses. And I think it's also important to develop work group at the national level. Because even if a model is developed, it's fair, it's applicable, and it's generalizable all around the globe, every country has its law in terms of applicability and use of health-related devices. And so it's important for each country to make sure that we can use that particular model, or which are the constraints of each country. And finally, again, it's also important to collaborate and to talk with data scientists and develop a common language that would allow to be always in the pipeline development of this algorithm, being able so to maximize the efficiency and the safety both for neurosurgeon and for our patients. I thank you very much for your attention. I'm going to take any question that thank you again for the invitation. It's always an honor and a pleasure.
Thank you very much, Alessandro. It was a very interesting and exciting talk. So before I start off with the questions, I just want to bring us up to date because today is Professor Satiro. You're already online, right? And also just to take over, just in case I have to leave, my vice chair, Professor Anila Darba, she's also joined in, so she will also assist. And our discussant for today is Professor Alexandra Wozniak. So shall we start off with questions from the floor for Professor Alessandro Boro? Any questions? Or maybe start off with Professor Alessandra.
Sharon, maybe Dr. Miyawaki Sensei has joined.
Yes.
So, of course.
Yeah,
he can
sorry
take over, yes.
Yeah.
Yes,
Okay, so
Okay.
I'm sorry to be
So
late.
Professor Miyawaki, I let you take over and share the
Okay. So thank you for Sandro. Thank you for a very nice talk. Very interesting. I learned a lot. So, are there any questions from the audience?
So can I, Miyawaki Sensei?
Yes, Professor
Boro.
Patrick, please.
Always. Thank you very much for exciting the lectures, as always. So in neurosurgery, now is changing so many things, especially the treating way or surgery itself, or of course the minimally invasive treatment, and of course the patient wish to non-invasive treatment. So I think how do you think in 5-6 years, how we change the neurosurgical surgery itself? How do you think? Open surgery is no more, or how do you think about?
So I think, in my opinion, in 5 years, I think that the situation is not going to be very different in terms of the day-to-day work as it is now, but it's just because the process of implementing new technology in healthcare, it's slower compared to other industries because there has to be really more attention to detail and to safety of the patients. The areas in which I think there's going to be the higher changes is from not specifically in the surgical theater, but before and after. So if we think about the possibility to improve the diagnostic capacity, looking into, for example, MRIs and trying to understand if a particular tumor has a specific type of molecular signature. If we were able to do that, and there are different studies about it, we can also think to tweak and to personalize the surgical strategy. Otherwise, we wouldn't be able to. On the other hand, is that after the surgery, obviously we have to follow patients, and the ability to acquire and analyze data from personal devices would help in having a better understanding of their recovery trajectory, and also to maybe prevent the occurrence of complications. So those are, I think, are the two part in which there's going to be the higher, the most important change over the next year. With regards to the surgical theater, I think that, and this is something that already started some time ago, the robotics, the augmented reality. I'm thinking more about spine surgery, as I'm mostly involved in that. This is something that is happening now. So the use of augmented reality, and so the reduction in the exposure to X-rays and the reduction in time of the surgery themselves, and all the ability to use this headset that make it cheaper compared, for example, a surgical robot to do surgery to the spine with screws and bars. That's something that I think is going to be more diffuse over the next 5 years. I think this would be the change I would expect in this short period.
Thanks so much. Thank you.
Thank you. So
Thank you.
we have a discussion. Professor Wozniak, could you make some comment?
Thank you, Professor Miyawaki,
Mhm.
for this one. Dr. Buaro, thank you very much for great presentation. I was listening for it and also analyzed the information I got. According to my age, I'm closer to academia group, and so I'm a little bit critical in some positions of AI implementation. If we speak about neurosurgical equipment, of course, it's we see every year new equipment. It gets more and more easy to work with it. It gets everything less dangerous for the patient, less difficult for the neurosurgeon. It's very good. It's absolutely. When you go to the another stage, to the stage of machine learning, I think here we will have some collision in switching from machine learning to real surgery. Theoretical, of course, theoretical education is very good. It's excellent. We can use it. But when we go to when we move to machine learn of surgery, of our surgical skills, the situation there is absolutely different from the real surgery inside. And I think here we can have some problem, and we must agree this like a smooth moving from machine learning to real surgery, and keep the balance between this. And the last sphere and last area where I think AI could be even dangerous, it's clinical considerations. We used that it's based on our professional experience. It's based on group experience, on the evidence-based medicine. And I'd like to warn everybody to replace the real clinical minding by the machine consideration based on only on the evidence-based medicine, on the statistics. So I think in this sphere we must be very careful with AI, because if we will rely on it, it may lead to degradation of us as doctors. So it's my position, like a discussion. But in general, of course, we cannot stop this process, but we must control it and accept it under very big critical control at every sphere of implementation of AI. So this is my position. Thank you.
Thank you, Professor Wozniak. I completely agree with you, and you touch two very important and fundamental points that I didn't do in my presentation, which is to try to sum up what my view is. It's true there is a lot of hype about AI, but AI is really just another technology. So we have to always be able to be in control of it. And I think the ideal scenario would be to take advantage of all the powerful calculations and analytics properties of the techniques, but always consider it as a support to the surgeon. As for now, I don't really envision, and I wouldn't be, it wouldn't be ideal for me to have to consider a future in which the surgeon is not in the picture. I think that AI solutions should be another tool to improve our work and to make it maybe safer and more effective. But I completely agree. We have to always be in control to take things slowly. And that's the reason why we started with this survey, with this work, to really understand what is our current knowledge. Because without knowledge, you cannot take decisions and be informed. So thank you very much for your for the specification of the points.
Thank you.
Thank you. So I have, I myself, I have one question. It could be similar to Dr. Yoko, Professor Kato. So what is your opinion? So what can AI specifically do at this point, present? What could AI do in the clinical practice of neurosurgery? Like it could be a diagnosis or a treatment strategy, or could they help a surgical procedure? What is your opinion?
So you're
So
asking
as
me
for
or
now, what
what?
we can,
Yes, Gaurav, please.
sorry.
Yeah,
Please,
Sorry.
Gaurav.
yeah.
Gaurav,
Please,
please.
Professor
Yeah,
Kato.
Baro, yeah, I don't know. This is a question to Dr. Baro.
Gaurav, yes,
Okay,
please.
okay.
Yeah.
Okay, thank you. I'm sorry.
Mm,
What's now it's been used and are mostly algorithm to, as the one that I make an example, I'm providing as an example before, like segmentation algorithm. These segmentation algorithm have been around for 6 or 7 years now, are really, really powerful and very precise. And so the ability to have your MRI before surgery and to provide and to develop models that can be used along with tractography, for example, information to plan your surgery, that's something that is already here. Another example are segmentation algorithm not only for pathology, but also for physiological anatomical elements. For example, when we think about the spine, there are a lot of very good segmentation algorithms for the vertebrae. So you can plan your surgery in advance. And so again, reduce the amount of X-rays that you're exposed to and that the patient is exposed to. So as we know, radiology is the realm in which, because of the great amount of data, the systematic way in which the data is collected, the PACS basically system, it's where it's being already applied. Within the surgical theater, we may think of, for example, robots in terms of machine related to some sort of artificial intelligence, a bit of a stretch model. That's something that's already here. But again, in this case, are very, very simple tools because we're just using robots to eliminate the hand tremor, basically, and just in straight trajectories. So we're not having the robot decide what to do. We are just using it for its mechanical properties. In the operating room, there is a lot of data that can be collected. As for now, that I know of, there are no application in terms of trying to put all this data together. Again, in the post-operative uh, uh, period, there's starting to be models that focused on the use of digital personal devices. They're not mainstream, but they're starting to be there. So that's why I think also these two areas are going to be the one most implemented in the next years. But again, for now, mostly related to radiological information and help in the navigation into the surgical theater, but no more for now.
Thank you so much for very important information. And another question. So, into your opinion, could the AI take over human neurosurgeon? Could AI do surgery by themselves? What is your idea in the future?
Well, I don't know. In a way, I hope not. Because of what Professor Wozniak was saying before, I think the human element is really something that we should not remove from the picture. If I think myself that I've been studying this whole topic over the last almost 10 years, I still wouldn't feel comfortable on not having a human, even if with the flaws of that any human can have. But I think that's the ability to increase the focus, to feel that under your arm there is another human being, are something that cannot be replaced. So that's why I think it's difficult to think that the surgeon would be out of the picture. If I think that it's possible, well, that might be. It might be possible. I don't know in how many years to have such an advanced, robotic entity that will be able to do that. But I don't know. I don't think it's gonna be well the best scenario, in my opinion.
Okay, thank you. So, is there any questions?
Yes, Anita.
Okay, Professor Kato, please.
No. Anita?
No?
Yes, please.
Who is it?
Is there Anita?
Anita.
Sorry, just
Yes.
a quick
Hi, how are
question.
you?
I am very well, thank you. I personally believe that the AI, the way it's advancing, and like simple chat GPT and things like that, that's been out there very commonly used, it's a very self-learning tool, which means that the more input you give, the more it learns. So it's a possibility that in our lifetime, a robot may not be doing a surgery, but I really believe that the more AI will learn from us over the decades, it will at some point in time will be able to perform surgery, and we will only become decision makers in the end. It may not happen in our lifetime, but I certainly believe that it's going to happen in future. So I just want to add the comment.
Thank you, Anita. Thank you for important comment.
Thank you.
So, okay, so is there any questions or comment? Okay, please, Ahmad. What?
Yes. Hello. Thank you very much. Thank you,
Hello.
Professor Baru. Hello. Hello, everyone. Professor Kato, and thank you. It was really exciting lecture. And just I like to say that's the human is decision maker. Even the science become improved and take the field, but the human is decision maker. Just like to say that. Thank you very much.
Thanks so much.
Okay, thank
Yeah,
you. Hi, thank you. So, Professor Wall, thank you for very interesting and very important topics. So we have to keep on updating our knowledge about AI and hopefully not to be taken over by AI. Okay,
Absolutely.
thank you so much.
Thank you very much.
Okay, thank you very much. So we'll move on to the next. So we'll move on to the next speaker. Next speaker is Professor Evelyn Rojas. Are you ready for the presentation, Rojas? Professor Rojas? Is she here or not? She's not.
Yeah, she's here.
She's here?
Are you there? She's
Sorry.
online.
She's online.
Yeah, she's here.
Okay.
Yeah, she's on. Oh, yeah, she's here.
Okay. Professor Rojas, could you start your presentation?
Yes. Oh,
You see
Aaron,
me,
so it's okay.
right?
Yes, yes, we can see.
Okay, we can see your presentation. So could you start your lecture?
Okay, thank you. Mm. Can you hear me?
I hear you.
Yes.
I hear you. We hear. We can hear you.
Thank you. Thank you very much. My topic is achieve a safe and effective learning curve in microneurosurgery. This is the question when I finish my resident and I start of neurosurgeon. I am Peruvian neurosurgeon. This is a little about myself. I am Peru. When I finish my resident, I start my fellowship in Brazil with Professor Ferres in these years, and the last year in Japan with Professor Kato and several professors in Japan. This is the hospital when I work, and then I study. In this is the first hospital when I work. Oh, I was here general neurosurgeon in this, and this is the institute that I work of vascular neurosurgeon. And about the clinical learning curve, and I read this article in this book of complication in neurosurgery. And this article, a clinical learning curve should be avoided in neurosurgery. No? The message of this article is do not train on patient. No? Use the simulation and the lab model first. And the learn through the training, the structured mentor training is essential. The innovation must be ethical about harming during learning. No? And in this article, you see this graph. No, the graph show the simple techniques are the learn quickly, but complex surgeries require many repetition of the to achieve profits. This case, the curve is sigmoid. The progress is slow at first, then improve rapidly, and finally, this curve is established on the level of the mastery. No? This is very important. Many young this is another graph done, but it's for surgery in general. And how is the curve during the residence and on the first on the first years of the practice the specialist. No? And this is another I think it's not only about the learning curve. The microneurosurgery in this article mentioned the art of microneurosurgery and the passion for the technical excellence. No, the technical excellence is not innate. No, it is developed. Surgical efficiency protects both the patient and the surgeons.
And technical innovation should serve the patient, not the surgeon's ego. This is very important for know how how is for know how is the future in the neurosurgery. This is another article about innovation in the art of microneurosurgery for Richard 𝒂𝒂𝒂𝒂 ∑ relations. And the principal message as purpose surgical innovation. Innovation in microneurosurgery is not only technical, but strategic. No, it seeks better angles, greater neurovascular protection, and minimal invasion. Balancing. Another point is about the balancing risks and benefits. Need to choose to innovation approach involve evolution to its efficacy. The anatomical risks involved and surgeons technical training. But this, my first professor was Professor Ferres in Brazil, and he teach me more about the art of combination neuroanatomy and microsurgical skills in modern neurosurgical. No? In this, and the team of the fellow fellows and professor make this article, and the principle is the 3D anatomical knowledge guide and the safe surgical corridors. Microsurgical training improves the precision and confidence. Practice in the lab models reduces risks and the shape journals. And in this, and Professor Ferres promote than the fellows when training in the laboratory. When training in the laboratory, make the same in the operating room. In this match, see this is the same in the laboratory when training with the placenta dissection. That's the same position of the operating room. And in this graph, see the treatment of the ABM is the same when training with the placenta, the dissection of the vessel. And in this picture, see the bypass. See when the cadaveric specimen and in the placenta, no, is the fellows need to training the same in the operating room as in the lab. Have two great neurosurgeons say. Professor Yazarshil say that the microsurgical technique can only be acquired by daily practice for at least 6 months. It should never be forgotten that there are far more to microsurgery than more position of the high perfect optical instrument without bipolar coagulation, specialized instruments, and about all knowledge and skill micro techniques. And Professor Evandro de Oliveira from Brazil say many times of Professor Ferres say that he'd say when is the microneurosurgery a superior option? Professor Evandro say when done at a superior level. For this, I go to the laboratory. I stay more than more than 1 year in the training, not on during my fellow in Brazil. I stay in the operating rooms and stay in the laboratory training, not training in this section of the placenta, training of the bypass, and training about the dissection of the fibers, no? When I stay in Brazil, I think the solution for training in my country is that I have a laboratory for I make the same in Peru. But when I go to Japan, I training in the with another, not with a specimen. I training with this material for bypass, and I think this is better. This is better because not all the hospitals have a microscope, but have a microscope in the operating rooms. And with this material, it's possible to training with a microscope in the operating room of my country, of different hospitals. Or with this material, it's possible to training. Only I need to have a microscope. It's possible to training the same with these materials. And it's not important only, all the knowledge is not only for me. It's very important to share the knowledge and the skills with the residents. When I return to Peru, I teach of the residents. These are the residents in Peru, training in the placenta. The same, okay, I make in Brazil. And teach about neuroanatomy. And in Peru, not have a laboratory, but it's not big. Have a microscope. This is only, I have this microscope, only one in the is the small laboratory. But with this small laboratory in Peru, this year was possible to make this article. And this is my first article this is my first article that I published when I stay in Brazil with Professor Ferris. This was the first time that I participate in investigating and publish articles. But with the team and the institute in Peru, I was the same in a small laboratory with a team with another surgeons. Was possible publish this article. And I think that the microneurosurgeon will not disappear as along there, the great master who teach and disciples who understand its values. Our responsibility is to keep its electro technique, neuroanatomy, and training for the future generation. And I think this is very important. This is very important. The legacy of microneurosurgery from the master of the future generations. Professor 𝑑𝒓𝒐𝒏 many years ago introduced the use of the microscope. And this great master I think they have passion for the microneurosurgery, and then these great mentors in these continents. This is for me the great representative teach the actually great mentors, and they mentors teach more and more residents, no? Professor Cato teach me, and I think she teach me, or the Professor Tetsuo Kano. Professor Ferez many times say, all Professor Evandro de Oliveira say, and they transmit the passion of the microneurosurgery. I think it's the reason why the neuroscience don't disappear. Many years ago, have an article that say that the microneurosurgeon disappear, but I think if have more great master in microneurosurgery, this not disappear, and only change that techniques are more minimal invasive. This is very, I think this is very important. This is all. Thank you.
Thank you, Professor Rojas. Thank you for a nice presentation. So, is there any comments or questions from the audience? So, Dr. Kato, Professor Kato, please.
So, everyone, thank you very much for your nice presentation. So I think you remind us the importance of the anatomy study, and also the daily practice is very, very important. So thank you very much. Excellent talk. Congratulations.
Thank you, Professor Kato. And so Professor Wozniak, do you have any comments?
Yes, of course. I have a comment. Thank you very much. Thank you, Dr. Rojas, for a really great presentation. So you connected your personal experience with a very good literature review, with some emotional things. So thank you. I really enjoyed it. And I absolutely agree with you in everything you told, but I'd like to express my point of view. First of all, when a young neurosurgeon starts his surgery, he must have a very good theoretical basis. If a neurosurgeon doesn't read literature, no sense to work with the fingers on it. So neurosurgeon must always read and follow the latest tendencies in neurosurgery to build up his minding to his way in the surgery. Another step is very simple surgical procedures. You must always do them one by one, to put stitches, to so on. So everyday practice, what Professor Kato told, everyday hard work with patient in the OR, not necessary to do the complex things, but everyday practice for micro skills, it's very, very important. Then simulation procedures, what you told on placenta, of course, it's very important, it's very good. But the next steps is hands-on courses, where you work in the real cadaver, where you really study the anatomy. I think it's the last step before you can do the really serious and difficult microsurgery. And only after this, you can go to the real surgery. And but all this way, you must be supervised by your mentor. It's my advice to have a mentor. If you have no mentor, you have not aim, you don't know where to go, because neurosurgery is not only handicraft, it's like a sacrament. These skills and the philosophy transfers from person to person, like in Buddhism. It's very, for me, it's very important to have a mentor, to rely on him, and then become a mentor and teach your younger colleagues. And then final, I want to finish with the option of Professor Ali Krish. You know, a couple of days ago, he gave a talk at 𝑦𝒂𝒑𝒂𝒏𝒂𝒂 Academy, and what he told that learning curve for neurosurgeon is a lifelong process. It never ends, because every next procedure changes our skills, improve us, and changes our knowledge. So this is my point of view. Thank you.
Thank you. Thank you. Thank you. Nice comment, Professor Wozniak. So any other questions or comments? So can I ask one question, Professor Rojas? So is it in your country, is it easy to get cadaveric specimen? So you have a lab, so it is easy to, so like how many specimen can you like use for training?
The laboratory in the institute don't have the first I only training with the placenta. It's more easy
placenta. Okay, placenta.
But in the institute have a area of the pathology, and in this area, it's possible to I teach in the university of anatomy, and the specimen this I move for this site, and I move the microscope and I dissection in this, but not have it, the specimen cadaveric is the university. Is the no this, but I years ago one professor have one specimen cadaveric special for training, but currently it is not it's not easy. It's the specimen that I train for is the university.
Okay, I see.
It's not easy.
Understood. So in your opinion, what is the most, so placenta is the most best way for training? What is your idea?
I training more with the placenta. I think this is very important. And then during my fellowship in Brazil, Professor Ferris trained more ABMs, and for good, I need more dissection of the placenta. Is very I think it's very similar, and I think the microneurosurgeon need to stay more time with the microscope, and with the placenta dissection all the vessels, and I stay many hours, more than 6 hours, and I think the microneurosurgeon needs this, not needs stay more time with a microscope, because I think in many neurosurgeons, I think treatment that's understand, but not all try operate that the aneurysm, but but I think that it's not the word possible. I think that the operate that on rupture aneurysm are easy.
No.
Some cases are easy, but rupture is difficult. And with that, I training with the placenta injecting more. The placenta is very the vessel of the placenta is very expensive. You put 40 millimeters and you put more, and when you put more millimeters, more 80 millimeters, it's the same when the vessel is ruptured. I train in this with this. I think it's that difficult for training for rupture, for case rupture. For my opinion, the training with the placenta is very good, but I think not, but training with the other vessels is good.
Okay, thank you. And one more question. So the residents and fellows, neurosurgical resident fellows are usually very busy, very busy. So how could they make time for training? What is your idea? They should do the training, but they're very busy. So how could they make time for training? What is your idea?
I think that the fellowship that I sacrifice 1 year and training I sleep 4 hours during my fellowship in Brazil. But I think this is the only possibility for half time. It's difficult. I think it's more difficult in the residence, but in the fellow it's most possible for have this sacrifice for the time. But I think needs this sacrifice. The patient needs this sacrifice. And this time, for I sacrifice this time, I feel more confident in the surgery. And not only finish the training when finish the fellow, the training continue when I teach the young neurosurgeon, the resident. I think they need no need the resident, no need only the laboratory, needs one neurosurgeon in the same state with they need to teach neuroanatomy. I think the microneurosurgery and neuroanatomy, for me, I am more confident in the surgery, and I continue to training. And when I see my great mentors, their life is not easy. I see Professor Ferris don't sleep more. I think they sleep the same when I feel the fellow. And I think the Professor Kato is the same. And when you see your mentors working hard, you working hard too.
Okay.
And when you see the patient, when I see the outcome on say the patient, it's very motivating for me for continuing.
Okay. Thank you so much. So is there any questions or comments? Okay, thank you, Professor Rojas, for a nice presentation, and thank you so much. So we'll move on to the next presentation. Okay. So next speaker will be me myself. So I was share my screen. So I'm sorry. So could you see my presentation?
Yes, we can see.
Okay, so I was assigned to make a short presentation. One point related to microsurgery. So I'll talk about bypass surgery today. So my name is Satoru Miyawaki from the Department of Neurosurgery from the University of Tokyo. And it's a great honor for me to be given this opportunity. So as I said, I will make a short presentation about microsurgical techniques for bypass surgery. So bypass techniques are utilized not only for the prevention of cerebral infarction in cases of major intracranial artery stenosis or occlusion, and for preventing ischemic or hemorrhagic events in Moerman disease, but also in the treatment of cerebral aneurysm requiring parent artery occlusion. Despite the advances in endovascular therapy, bypass surgery remains indispensable microsurgical techniques in the management of cerebrovascular diseases. So the technique of bypass surgery involves not only the suturing of vessels, but also a series of essential procedural steps, including donor vessel dissection, craniotomy, and preparation of the recipient vessels, as illustrated here. Each of these steps carries potential pitfalls, and it is critical that the surgeon is proficient in all aspects of the procedure and can perform them without error. This highlights that vascular suturing is only one component of entire bypass operation. In this presentation, I will show actual surgical videos to demonstrate the technical details of bypass surgery. So this is the first video, 30-year-old female with ischemic onset Moerman disease. I performed bypass surgery on the right side. So first, I make a skin incision directly above the STA. I performed the dissection of STA under macroscopic view without using microscope. I'm sorry. Key point is to maintain bloodless field throughout the procedure. Anatomical knowledge of the precise subcutaneous layer in which STA branches reside is essential during dissection. I proceed without transecting distal STA to preserve anterograde flow. In this case, since EMS, indirect bypass, is performed as for Moerman disease, the temporal muscle is prepared accordingly. As the fascia will later be used during closure to prevent thinning of the subcutaneous layer. So for Moerman disease, it is important to perform the craniotomy with the care to avoid injuring middle meningeal artery. After a dural incision, the microscope is introduced. ICG video angiography is performed to select an appropriate recipient vessel. The arachnoid membrane is open and the branches around the anosmotic site are coagulated and dissected. And the rubber seat is placed. Next, the distal end of the STA is cut and the surrounding connective tissue is dissected and donor is prepared. It is important to ensure that the length of the STA is neither excessive nor insufficient for the anastomosis. To maximize the anastomotic surface, a fish mouth-shaped arteriotomy is made on the donor. And firstly, 10 nylon sutures are placed on both ends of donor vessel. and the arteriotomy site is marked with dye. Matching the anastomotic length to the vessel diameter is essential. After temporary occlusion, a microknife is used inside the recipient artery, followed by thorough irrigation of the lumen with heparinized saline. The incision then extended using micro scissors, and sutures are forcibly placed at both ends of the arteriotomy. Then intermittent suturing is performed one side at a time. While this technique can be practiced on gauze or artificial vessels or even chicken wing arteries, the most important principle is to handle both donor and vessel gently, avoiding contact with the endothelium. Efficient osmosis also requires effective use of left hand to stabilize vessel and apply counter pressure when driving the needle. So I'm sorry. Sorry. I'm sorry, the video is stuck, so I would. I'm sorry, I'm preparing once again for the presentation. I'm sorry. Okay. I'm sorry, my laptop is not doing okay. Could you wait for a while? Fixing my presentation. I'm sorry. Sure. So I want to share my presentation. Okay. I'm sorry. So could you see my slides again? I'm sorry. Sure. Sorry, my laptop is not working good. Okay. I'm sorry. So intermittent suture, and so about 5 stitches on one side and another 5 stitches on the other side. Before completing the last 2 sutures, the anastomosis is filled with heparinized saline to confirm proper expansion. Upon completion of sutures, the temporary occlusion on the MCA side is released first. ICG video angiography is then performed to confirm normal MCA flow, and under the same ICG observation, the occlusion of the donor side is released. And ultrasonography is used to confirm the patency of a bypass, and we make a EMS, and then the bulb flap is then fixed, and the wound is closed. Throughout the final step of the procedure, Doppler ultrasonography is used to ensure that the bypass graft is not stenosed and that blood flow remains adequate. And the post-operative MRI shows good patency of bypass. Here are some key points of knowledge required for bypass surgery in Moerman disease. This is a case of 36-year-old woman undergoing surgery for Moerman disease on the left side. After the 𝒓𝒐, you can see several vessels, candidate vessels for the recipient. It is important to avoid the reddish vessels like here. Instead, select whitish vessels as recipient because reddish vessels like these ones are very fragile, which may tear simply by passing a needle through them during anastomosis. In this case, a whitish vessel was selected as a recipient, and the anastomosis was completed without complications. As the case before, intermittent suture is made on one side, and heparin saline is filled after the last 2 stitches. And after declamping, we confirm the patency by bypass by ICG video angiography. And after that, we do the EMS, and the patient went good. And another case, here I would like to introduce another surgical technique. This is a case of 8-year-old boy. In Moerman disease, there are considerable number of cases like this one, in which no suitable recipient artery can be found on the cortical surface. So as you can see, there are no good recipient arteries for bypass.
宮木先生、ビデオ見えてないんですけど、大丈夫なんですね。
すいません。見えてなかったですか？すいません。
見えてない。
そうです。
先生の顔が映ってるだけ。
ごめんなさい。じゃあちょっと、I'm sorry. So I'm sorry. So I go back to the one case. So I'm sorry. Thank you for the comment. I'm sorry. So could you see my slide now?
はい。
Okay. So this is about the knowledge of the surgery. So you can see this is a case of 35-year woman undergoing surgery for Moerman disease. After 𝒓𝒐, you can see several vessels for the candidate for the recipient. But it is important to avoid reddish vessels like this. And instead select whitish red vessels as recipient because reddish vessels like these ones shown here often have extremely thin and fragile vessels which may tear simply by passing a needle through them during anastomosis. So in this case, a whitish vessel was selected as the recipient and the anastomosis was completed without complication. So after the ICG video angiography, I selected this white vessel for the recipient. And as the other case, we make the stage suture first and make an intermittent suture one side by side. And before the last 2 stitches, I fill the anastomosis side with heparin saline, and I confirm the patency of bypass by ICG. So I will move on to the next case. So this is a case of 8-year-old boy. So in Mohammed disease, there are considerable number of cases like this one, in which no suitable recipient artery can be found on the cortical surface. As you can see, there is no good recipient in the surface of the cortex. So in such a situation, ICG video angiography is particularly used for identifying in which sulcus is likely to contain variable vessel. So, so I suppose there was a suitable recipient under this sulcus. So the sulcus was carefully opened in a brain-sparing manner, allowing identification of the recipient artery. After managing the surrounding branches, a rubber set was placed underneath and to gently elevate the vessel and optimize the environment for anastomosis. So once again, the bypass is done after placing stitch suture on the both side and suturing 4 stitches on one side and going to the other side. And the patent of bypass is good. After that, we perform EMS, and after the post-operative MRA shows good patency of bypass. So here I would like to once again present the steps involved in bypass surgery. It is essential to carry out not only the vascular anastomosis, but every step of the procedure safely and reliably. So an overview of microsurgical techniques surgery was provided. To perform bypass surgery safely and reliably, not only daily practice, but also comprehensive knowledge and understanding of every procedure steps are essential. Thank you for listening. And I'm sorry about the video trouble. So is there any comments or questions?
Of course, one comment from Bosnia, please.
Professor Miyawaki, thank you very much for great presentation. Actually, I have no comments because I only want to thank you for excellent cases, excellent surgery, excellent microsurgery, and also I'd like to conclude that the bypass surgery will never die, and because it will always will have a right to live and develop, and microsurgery, bypass microsurgery is like a good basis for any kind of microsurgery in general. So thank you very much again. Thank you.
Thank you for a nice comment.
So 𝒓𝒐𝒏𝒄, please.
Thank you so much, Miyawaki Sensei, for this
Thank you.
Presentation. Yes.
Mm-hmm.
What is the maximum amount of time that should be used in bypass establishment?
What do you mean? I mean, the training? Training? You mean the training?
No, I mean the duration of bypass. How much time should be the maximum time to do the bypass?
Maybe I usually do the bypass procedure around 20 minutes. Maybe 30 minutes is okay. Maybe 40 minutes may be okay, but more than 40 minutes, maybe it may be too long. So yeah. To my opinion, less than 30 minutes is mandatory.
Okay. Thank you.
Thank you.
Thank you so much. Of course, we learned a lot from your technique, especially the Moya case. So yes. You emphasize about the ICG technique, how you can find the receiver, good receiver. Thanks so much. Excellent talk. Thanks.
So
you can proceed. Next one.
Rojas, you have a question, Professor Rojas?
Yes, excellent presentation. I have two questions. if you need for confirm the patency of the bypass, if you need to choose ICG or ultrasound, why do you choose to use?
I'm sorry, again?
If you need to choose one ICG or ultrasound, why do you choose? Or in all the case you choose, you need to choose both.
Yes, actually, I use both on all cases. But to my opinion, ultrasound is more important because every step, like the closure, I check the STA, the patency of the bypass until the closure. ICG, I can do two or three, one or two times in one operation, but ultrasound you can do again and again. So I think ultrasound is more important in bypass surgery. That is my opinion.
Indispensable. Do you think that if I don't have ultrasound, I don't have ICG, don't trade bypass? In years or years ago, years ago, don't use ultrasound or
in your country, you mean?
そうそう。両方なかったらどうやって確認するかって。
Very difficult question. You can like feel by hand but the SDF, but I think so like the patency of the bypass, like in the MCA, I think it is the ultrasound is it's the only way we can see the patency. So hopefully we have ultrasound in every case. That's my opinion.
I think. My second question is about when you use the ICG and you see a thrombus, what do you? If you see a thrombus.
Yes. I firstly like gently like crush and hopefully like it flows out. But if there is still thrombus at the anastomotic site, I clamp and open and flush and clean the anastomosis site. But usually once you get like clot in the anastomosis site, it is very difficult to recover, especially in the Moeme cases, because the vessel is very fragile. And the endothelium, when it hurts, like injured, it's usually very difficult to recover. So once the anastomosis site gets occluded by the thrombus, I cut and make bypass another recipient. That's what I do. Like usually, once again, in Moema case, it is very difficult to recover when it gets clot, like a thrombus is in the anastomosis. So I use antiplatelet before surgery to avoid thrombosis the anastomosis side. I use heparinase saline again, and I also be careful not to injure the endothelium, both sides on the MCAs and also the STA. So the surgical, the preparation is very important. And also like using antiplatelet is also important. But if you get clot, to my opinion, it's very difficult to recover, especially in Moema case. That's my opinion.
In Moya case, if you say another bypass in another site, but if you make a indirect bypass too?
Yes, I always do combine. Do you mean direct and indirect? So I do single bypass, single direct bypass, and also EMS using temporalis muscle. That is my procedure.
two. Okay.
Sorry.
About the if you it's all. Thank you very much for.
Okay. Okay. Thank you, everyone. So this is all for today. Is there any comments or questions?
じゃあ先生、次にこの、ノーユーウィンってのがあって、カザフスタンの人たち。ポスターの右下に書いてある。次、見てください。
I'm sorry. Yeah, I'm sorry. Okay, I'm sorry. So next, we move on to the next presentation. So Dr. Maidan AM. So could you start your presentation? Ayman, could you start your presentation?
Thank you very much. It's very good. I'm so glad to be here. I hope you're having a good Easter. Do you see my screen? Do you see my screen?
Yes, yes.
We can see your slide. Thank you.
I will be very short as we have limited the time. So I wanted to become a neurosurgeon even before. I was like one-eye child, and my university I completed in ACNS Medical National University in Almaty with honors and the best graduate, and then I also received like IFOM result, one of the best in Kazakhstan. During the internship, I met Professor Takizawa from Japan, who also taught us a bypass technique, and he taught us a two forceps technique, not a needle holder, and also met Professor Luis Borba. He was in a cadaver course in Tyumen in Russia, and then I started my residency in Astana, Kazakhstan, where I met the best group ever and my most favorite mentor, and where I also got the Professor 𝒂𝒂𝒏𝒄𝒄 award. Then after the residency, I went to USA, where I attended a Congress of Neurological Surgeons and attended the Emory cadaver course, then went to a 3 months experience with Professor Michael Lawton, and then 1 month with Professor Giuseppe Lanzina. And currently I'm starting the job in an emergency hospital. And we are so proud of being part of ACNS. Currently there are 23 participants. Some of them still did not write their names in English. When they will, we will update the website, I hope, and another 2 participants will be presenting today as well. And Professor Yoko Kato, 3 of them also applied for a fellowship at your esteemed hospital.
So much, Ayman. So maybe you can introduce your colleagues. 宮城先生、もう2人ぐらいいるんですよ。
Hi, I'm sorry. I know. So next presenter, Kanatov. Kamutamba?
Camila
Are you ready? Kanatama.
Yes, I'm ready, dear colleagues. Hello, everyone. Allow me to introduce myself. So my name is Kamila Nauruzbaeva, and I'm currently a neurosurgery resident based in Astana city. And now I work at the multidisciplinary city hospital number 3 in the emergency department. I'm on duty twice a week for 24-hour shifts, during which I perform emergency surgeries under the supervision of my mentor, which is also the chief.
Can you share your slide?
I do not have slide.
Okay. I just understood.
Yeah.
Understood. I'm sorry.
Yeah. So I'm on duty twice a week for 24-hour shifts, during which I perform emergency surgeries under the supervision of my mentor, who is also the chief neurosurgeon of Astana City. And it is a great honor and joy for me to announce that I have joined the Association of Women Neurosurgeons under the Professor Yoko Kato. And this is an important step in my professional journey, as I strongly believe that in the power of support, mutual assistance, and the exchange of experience among women who have dedicated themselves to this complex and noble specialty as a neurosurgery. So with great enthusiasm, I also hope to take part in fellowship worldwide and learn from my colleagues around the world. And also I hope to take a part in fellowship in Japan. I hope that being a part of this association will help me grow as a specialist and also allow me to contribute to the development of neurosurgery. And yeah, thank you for your attention. It was a great joy.
Thank you so much. And another speaker, Dr. Dosim Nazark. Are you ready? Is she here or not?
I don't see her. Ayman, is her with us now?
I'm not sure if she was here now, but she must have left.
Sorry.
I'm sorry for that.
Okay. I'm sorry for my shortcomings in my duties in chairperson. But thank you so much, everyone, for the presentation. So, last comment from Professor Kato?
No, just Bosnia, please. You can encourage the Kazakhstan women neurosurgery, please.
Okay. So, I hope.
Bosnia. Any encouragement for them?
I'm sorry. A couple of, thank you very much for invitation. Thank you very much for choosing this topic because it's really important for our younger generation, and not only younger. The questions of training, the questions of developing and growing up of young neurosurgeons to the level of master is very, very important. And in this term, I want to express my gratitude to Professor Kato for your efforts in support of young neurosurgeons from developing countries, for sharing of your experience, for the abilities to visit your clinic and university. And I really appreciate this your activity, and I'm ready to support it. All the kinds of I can do. I can. Thank you very much. Thank you.
Thanks, Bosnia. So just the Kazakhstan women neurosurgery has just established. So congratulations. I think almost 10 members now. I think. Miyake-sensei, sooner or later, the two lady Ukraine female neurosurgeon will visit us.
Okay.
Yes.
Maybe I think during that time, maybe they can visit you in Tokyo.
Yes,
University.
of course. My facility is always welcome, and also visiting OR. My OR is always welcome. So if you have time to come, please visit our facility.
Thank you very much. Thank you.
Okay. Thank you.
Anila, are you with us now?
Yes, I am. Can you see me?
Yes, of course. Yes.
Yes.
Thank you, Dr. 𝒂𝒂𝒂𝒂𝒂. And I just want to welcome our Kazakhstan colleagues to the WIN ACNS. And I just want to say that my mentor, the one that I actually always look up as far as women in neurosurgery is concerned, has always been Dr. 𝒂𝒂𝒂𝒂, who I have in my 20-year career seen her just educating neurosurgeons, whether they are male or females, over the entire world. And I'm really, really thankful, Dr. 𝒂𝒂𝒂𝒂, that all over these years that I've been seeing you doing this, and you have done a tremendous amount of work for all the young men and women neurosurgeons in the world. For the Kazakhstan ladies, I just want to let you know that my services are readily available. Please contact me if you need any help regarding fellowships in US or UK, because I have been trained there. So I also help in other fellowships, like from the Federation of International Education of Neurosurgeons. I help them sponsor the fellowships. So if anybody has any interest doing fellowships anywhere else beside Japan, in any other parts of the world, please do contact me, and be really happy to help you guys out. Thank you so much.
Excellent. Thanks so much. 宮城先生、ありがとうございました。
Okay, so finally, so this is all for today. So thank you everyone attending this webinar. So I hope for the nice future for everyone. And this is all for today. Thank you so much.
Thank you.
Thank you.
Thank you so much. Okay.
Thank you.
See you again.
Thank you.
Anita, all the best.
Thank you.
Thank you, Dr. 𝒂𝒂𝒂𝒂𝒂. Thank you so much. Bye-bye.
Thank you.